Okay, we'll just get started. So thank you all for joining us today. This is another one in our series of SPSP acute adult deteriorating patient webinars. And today we're going to take some time this afternoon to talk about shock to survival, a structured response to the patient with cardiogenic shock. My name is Gregor McNeil. I'm an ICM consultant in NHS Lothian, and I'm the SPSP acute adult lead for patient deterioration. Next slide, please. As per any HIS meeting, if you've been to these before, please, when you're within the meeting, mute your mic and turn your video off just to save everyone's struggling bandwidth. If you do want to make a contribution, and there will be opportunity towards the end of the webinar today for Q&A, please raise your hand, and when you want to speak, you can turn your video on. Thanks. Next slide, please. If you do have any technical issues today or any technical disasters, HIS team are on hand, so please put a comment in the chat or email the HIS team directly on that email address there. Thanks. Okay, so this webinar is due to run till 3:30. And what we really want to do today is take this opportunity once again, if you're not too familiar with our programme, give you an update about the Acute Adult Collaborative that's been running across Scotland for some time now, aiming to improve the care of the deteriorating patient. We're really pleased today to be joined by one of the main authors of the Shock to Survival report that's been causing a stir in ICM and cardiac centres since its publication at the end of last year, and really getting an understanding of the topic of cardiogenic shock and how it fits into our own work in terms of improving the care of the deteriorating patient. So we hope to hear from the main author of the report and use that as a framework to think about how that will affect us in NHS Scotland, and think a bit about how the early identification of cardiogenic shock can maybe be aided by our own kind of work in terms of structuring the response to deterioration. Next slide, please. So this is how the next hour and a half is going to look. I'll give you a brief update shortly about the work of the Acute Adult Collaborative, and then we're really pleased for Alistair Proudfoot, consultant in critical care and lead for cardiogenic shock at Barts Health Centre, is going to talk to us about the Shock to Survival report, which he co-authored. Once we've done that, we're really pleased to be joined by colleagues across NHS Scotland who've all got varying involvement in this topic to get their thoughts about what the report findings really mean to them and what they think are the main issues we need to tackle in terms of improving the quality and safety of our approach to cardiogenic shock and the deteriorating patient. So that will run till about just after 3 o'clock. And then we hope to really involve you all who are on the call, get your thoughts in terms of what you've heard, and your thoughts about ways forward as well. After that, we'll close with a comment from myself about next steps and some further events that may be of interest to you. Okay, so next slide, please. So, as some of you will know, the Scottish Patient Safety Programme has been running for well over 10 years now and trying to improve the care of patients in Scotland. And one of the first parts of the SPSP programme was the Acute Adult programme, which aimed to improve the care of deteriorating patients across Scotland. And how do we do that? Well, we do that through collaborative pieces of work. And our overall aim has really been the same over the years that we've been doing this, in that we are aiming to reduce the number of cardiac arrests that are happening in our NHS boards across Scotland. Our latest collaborative launched in third quarter 2021, and it's recently been extended till March 2024. So all across Scotland now, boards are submitting data on their cardiac arrests. We have many tools available on the SPSP his website to kind of give you more information about the collaborative. But we have several pillars that we use to try and drive forward a reduction in cardiac arrest. Some of these involve the recognition of acute deterioration, spotting a patient as deteriorating, having a standardized approach to the deteriorating patient. And then once we've done that, working out what needs to be done, safely communicating that across different care pathways. And for those of us involved in that quality improvement work, whether it's from the quality improvement aspect or clinically or both, providing leadership to improve that culture of safety. Now, over the running of the collaborative, for many years, we've really focused on the general aspects of the deteriorating patient, but increasingly we've been looking at specific syndromes, and it's probably fair to say over the years that we've been running the program, we've focused a lot on things like sepsis. And you'll all know sepsis 6. You'll all know that we've kind of published specific driver diagrams on sepsis. But I think one of the things we've been appreciating more, particularly in the post-pandemic period, is that there are other clinical syndromes that we need to react to. And one of the things that has maybe been less publicized, but is increasingly recognized, is the challenges and the complex challenges when patients present with other clinical syndromes, such as cardiogenic shock, because the recognition is difficult. There may not be a standardized response in place for that patient. And there are clearly challenges around communications within your own hospital setting, but maybe across hospital settings, across boards. And it's certainly an area that we may be looking for leadership for in terms of improving things. So we thought this was a very relevant topic. Next slide, please. So I'm really pleased that we have the chair of Shock to Survival report with us today to talk about this report. So Alistair Proudfoot is a consultant in critical care and a lead for cardiogenic shock at Barts Heart Centre in London. Alistair hails from Glasgow. He did his undergraduate in Edinburgh and then moved down to London in 2004 to undertake ICM training. He completed training in respiratory and ICM in 2015 and was also awarded a PhD at the Imperial College. And he's been a consultant in Barts since 2016, where he now leads the cardiogenic shock program there. He has a research interest in cardiogenic shock and as an MRC clinical academic research partnership to explore the host response to cardiogenic shock in partnership with Oxford University. The thing that interests us most is he was the working group chair of the Shock to Survival report, which was published in October 2022. It's been endorsed by a whole host of UK and also Scottish societies and was co-authored by the British Cardiovascular Society and the Intensive Care Society. We're really delighted that Alistair can join us today to talk about the report's finding and help us unpick what this means for the deteriorating patient in Scotland. Over to you, Alistair. Thanks.
Thanks, Gregor, for the very kind and I suppose humbling introduction. It's a real pleasure to be here, and I think when I sort of set out on this journey to try and pull all the societies and people together, I didn't really know where and how it would land, and just the mere opportunity to come and speak to a forum like this, I think, makes a lot of the work worthwhile. Next slide, please. So thank you. I don't have any conflicts to declare, aside from the fact that I may be myopic to the nuances of NHS Scotland. And just on that theme, I suppose, as a Scot speaking to what I assume is mostly Scottish people, probably get the fiscal elements out of the way up front, and just try and perhaps ask you to think of what I'm going to talk about as not complex change, but actually modifications of themes which you already are already mature within your systems. And a lot of people think that this is a forum to talk about expensive devices such as mechanical support. That is not the thrust of what I'm going to talk about. So please, think of this as leadership, as I say, modification of existing systems and processes, and not complex change. Next slide, please. So as Gregor said, the shock survival document was published in October of 2022. It is hosted on the Intensive Care Society website as the PDF, and that's the QR code if you want access to it. It's a reasonably long read. And I think what that kind of emphasizes is the syndromic nature, the complexity, the multiple kind of specialties, pathways involved in its care, but also I think the opportunities that perhaps the deficiencies in current care that we have present as I say, a real kind of position to move forward from, and hopefully improve outcomes for these patients, and I think qualitatively for patients and for referrers to have a better experience. Because one of the things that came about, and one of the stimuluses for this type of activity, was that from our district general hospitals, of which I've got 9 that refer into my centre, a lot of the historical kind of commentary was of even when these patients were identified, there was no clear pathway beyond the advanced heart failure centres of where these patients could go, and often the advanced heart failure centres were either not set up to collect or accept these patients, or they didn't have the capacity. Next slide. So as Gregor says, it was quite one of the biggest challenges was pulling these multiple societies together. But as I say, I think what that speaks to is the heterogeneous nature of cardiogenic shock, but also the fact, and I think again this is one of the challenges, is that these patients present across the hospital footprint. So it's not just a problem of cardiology or critical care. These patients can present in EDs, they can present obviously pre-hospital, they can present in acute medical units, obstetric units, toxicology units. And again, I think, as I say, to reflect that, what we wanted was a very broad brush of societies to give their input. I think also somewhat reassuringly, albeit that not everything I speak to will resonate with NHS Scotland, we had representation from all the devolved nations, and what we tried to do was to create a document that was as encompassing and as generic as possible, that really reflected, I think, the other theme of the document as a whole, which is the probable variation in care, and I'll speak to that in the next slide, but also creating equity of access to specialist care if that exists, or if that is to be developed. Because I think one of the challenges I face working in a cardiac centre is that I'm reasonably confident that patients are offered equity of access, and one of the reasons for developing the pathway in my sector was to improve equity of access. But I'm pretty confident that that doesn't exist nationally within the UK, and I think that's one of the other drivers behind this. Next slide. So I mean, obviously the first challenge is to frame the problem, and that is a challenge, because we don't really have particularly good data in the UK to describe cardiogenic shock, despite the presence of intensive care audits in England, Northern Ireland, Wales, and Scotland, as well as cardiac audits, specifically NICOR in England. And so we don't really understand the true instance of cardiogenic shock. There are data from Australia and Germany that point to it being somewhere between about 15 and 50 per 100,000 patients. But we don't really know, and most of the data that we lean on are from international registries and observational studies. The commonest etiology is acute coronary syndrome, and patients who have ACS or AMI cardiogenic shock have a mortality of around about 50%, depending on which randomized control trial or observational study you look at. There is a suggestion that that may be trending downwards with the sort of evolution of systems of care, but I think at best you're looking at a 30 to 40% mortality of at least AMI cardiogenic shock. That said, again, data from North America suggests that the commonest reason for critical care admission is actually non-ischemic cardiogenic shock. And again, that's one of the drivers behind this, that the patients with AMI cardiogenic shock, albeit that we don't, I'm again reasonably confident, provide them with the best care always, but they're reasonably binary in that they present with a binary diagnosis, whereas the syndromic and often kind of non-specific nature of illnesses like myocarditis present one of the biggest challenges, and they are the more prevalent patients, it would seem, in the intensive care unit. And I think on top of that, we have relatively little data to describe how care is delivered. So which patients are referred when, what their outcomes are, how they're managed, where they're managed. And again, I think that presents challenges. And I don't think it would be controversial to say that there is probably significant variation in care and inequity of access to high quality care across the UK. So, I mean, I think in summary, I mean, some people may argue that this is a bit of a unicorn, but as Gregor has alluded to, and I would certainly say from our experiences, when you set up these pathways, the patients do appear. So it is commonly encountered, not as common as sepsis, but I think it's more common than most people would appreciate. It is often under-recognized, and I think that's part of what contributes to the high mortality. And there is a persisting high mortality and very limited data to guide our practice. Next slide. So the first step, and possibly the highest impact step, and yet the simplest step, is just to increase awareness through, opportunities like this, and extending the kind of narrative that every patient who has hypotension or hypoperfusion, more importantly, does not have sepsis. And I think it has obviously been great for the narrative in sepsis, sepsis 6, and the kind of escalation of sepsis is very clear. But I think what we do need to not do in that process is underestimate the incidence and prevalence of other syndromes and shock syndromes. And so I think the biggest thing that we can do from events like this is to increase the awareness of cardiogenic shock amongst those teams that are likely to be presented with those patients, be that critical care outreach, be that acute medical teams, emergency department teams, cardiologists, specifically in a response to a high NEWS 2 score, but with evidence of hypoperfusion as opposed to hypotension. So hypoperfusion is the exemplar here, not hypotension. How do we recognize hypoperfusion? Well, it's patients who are confused, it's patients who are cool peripherally, they're oliguric, they've got abnormal liver function tests, and then biochemical evidence of abnormal organ perfusion. And to emphasize, analogous to sepsis, that there is a high risk of death from cardiogenic shock. And that plays into early recognition, early identification, reversal of the underlying cause where that can be identified, whether it be STEMI, whether it be P, whether it be cardiac tamponade, but really acting on trying to identify the etiology. And if the etiology isn't clear, then managing the syndrome itself. And as I say, highlighting that hypoperfusion is the exemplar with or without hypotension. And there is an increasing recognition from within observational data sets that around about 10 to 20% of patients don't have hypotension. And then emphasize that if you identify these patients, that should be followed by ancillary testing, specifically focused cardiac ultrasound, where there is evidence of hypoperfusion, or those patients who have shock that is refractory to standard measures, be that fluid resuscitation, antibiotics, etc. Next slide, please. So what are the warning signs? We really tried to kind of pare this down, and we propose an elevation of NEWS 2 as the initial step. The reason, so there are no data that speak to NEWS 2 being prognostic for cardiogenic shock. That data will hopefully follow. But NEWS 2 is obviously embedded in our practice. It's easily collectible data by healthcare assistants, by nurses, by doctors. And so it seemed counterintuitive to move away from it. And as I say, we emphasize the importance of NEWS 2 being the initial primer to be followed by signs of hypoperfusion, particularly cold mottled extremities. an increased lactate level, be that venous or arterial, on a background of existing or new cardiac pathology, including heart rhythm abnormalities. And that really plays into those patients who have bradycardia with a fixed cardiac output. And then a shock state where the cause is unclear or it doesn't respond to initial management. And then we also put in a narrow pulse pressure, which we defined as less than 20 millimeters of mercury, as potential warning signs or triggers to think about cardiogenic shock. Next slide, please. And so then, as I say, that should be followed by focused cardiac ultrasound. Now I accept, and we accept in the document, that this is a very easy statement to make, and it's a very difficult service to deliver. Nonetheless, I think on the background of getting it right, first-time cardiology, failure to function, at least in England, there have been moves by Health Education England, by the British Society for Echocardiography, to democratize echo. And echo is not just important in cardiogenic shock. It's important in steady state. It's important for volume resuscitation and many other facets of the deteriorating patient. I think, you know, that will obviously be one of the greatest drivers for resource, but I think it is probably not unreasonable to say that cardiogenic shock identification should be, as I say, one of the drivers. The other point that we made in the document is that we don't necessarily have to lean on critical care or cardiology. Increasingly within emergency department training, within acute medical training, coupled with, as I say, intensive care training, cardiology, and just general medical training, there is an increasing cadre of people who have at least basic focused ultrasound capability. And what we should be doing, and what we propose in the document, is to utilize that cadre of people across the hospital footprint, as opposed to leaning on critical care. And perhaps, for example, if it's out of hours provision that's going to be the biggest challenge, then at hospital at night meetings, for example, identifying what capability you have in-house. Now, there is never going to be 100% coverage on every shift, but I think there should be a recognition that we need to utilize the people that have the capability within our hospital footprint at any time of day. Next slide, please. And the other thing we emphasize is the use of the SKY classification. For those of you not aware of it, it was originally published in 2019 and then revised in 2022. And there are a couple of reasons that at least that we put this in. Firstly, that it creates quite a nice but common vernacular for people to describe the state of cardiogenic shock from at risk all the way up to extremis, with the descriptors there. What we will, you know, most of us who've seen it before, I think would recognize the classic patient who has evidence of hyperperfusion, who requires a bit of inopressor support, plus or minus ventilatory support, and hypotension is usually present. But the two things that really drove us to incorporate this are that there are data in over 20,000 patients across a range of presentations in cardiac ICUs and patients who've had out of hospital cardiac arrest. But importantly, as you move from, and intuitively, as you move from stage A through to E, there is a sequential and linear increase in mortality from around about 2% if you're at risk, all the way up to somewhere between about 50 to 70% if you're in extremis. And so not only can you start speaking a common language within your center and to the cardiac centers that you may be referring to, but also what the stage should allow you to understand the expediency of your interventions and possibly the transfer of those patients to cardiac centers. Within that, and within the newest iteration, there are also modifiers specifically to include cardiac arrest, because again, it's well evidenced from observational studies, at least, that if you have cardiac arrest on top of cardiogenic shock, your mortality linearly increases across all SKY stages. So again, coupling not just SKY stage, but the presence of cardiac arrest and the details around that are important prognostication and triage indicators as you begin to think how quickly you need to act and what you need to do. Next slide, please. And so the next proposal that we made was to establish cardiogenic shock centres as the hub of regional shock networks. So this is already incorporated into ESC guidance, into AHA, ACC guidance. And again, I think it builds on existing networks of care that exist nationally. So we've seen qualitative and quantitative improvements in care in trauma and heart attack and stroke thrombolysis through leveraging the kind of cohorting of patients, the cohorting of expertise, volume outcome relationships in regional kind of hubs, and patients are moved into these centres as part of a network-based approach. And again, it's slightly kind of England focused, but the Getting It Right First Time Cardiology report that was published the back end of last year further emphasised the need for cardiology to work across networks and the benefits thereof. Next slide, please. So what would that look like in practice? Now, this is not going to incorporate every region or system, and it doesn't, for that matter, incorporate my system, because we're the only heart attack centre in my ICS. But what we sort of essentially propose is that there is a cardiogenic shock centre that has 24/7 primary PCI capability as a central tenet, because, as I say, the highest incidence of cardiogenic shock is in AMI, and we need to have the capability to manage that. Those centres should provide capability for a 24/7 shock MDT, which I'll talk about subsequently, that they have cardiac intensive care, all the related cardiology specialties and cardiothoracic surgery. They provide a range of short-term mechanical support, so be that univentricular or biventricular, so that they can be bespoke in their support strategies. They offer a retrieval service. They have advanced imaging, but also provide the capability for remote review, because one of the other things around ultrasound is providing network capability for people to capture the images, but also then have it interpreted centrally. And then all the specialty support that's required to manage these patients, be it through neurology, vascular surgery, palliative care, nursing, allied health professionals, etc. And the notion would be that if there was a heart attack centre within that network that referred into a shock centre, or indeed a non-HAC referring centre, they would use this news tube and focus-based escalation and sky-guided triage to refer into the cardiogenic shock centre using network-agreed protocols. And then the cardiogenic shock centres, now some of them could be advanced heart failure centres, but by and large, a bit like my centre, which doesn't have durable VAD or transplant capability, we refer into an advanced heart failure centre. And whilst those centres may in and of themselves be shock centres, one of the benefits, theoretically at least, of that model, and it certainly works in my network, is that we effectively protect the advanced heart failure centres from having this influx. I mean, albeit that they have the established expertise, from having this influx of acute patients taking up their bed base, which would hopefully be best utilised by, the advanced heart failure patients, and that we siphon off the patients that are stable, be that with or without mechanical support, have recovery of organ function, and have demonstrated advanced heart failure therapy kind of eligibility. I mean, obviously, with any network service, that needs to be underpinned by a sort of a robust transfer network. And for example, in my sector, we've been working very closely with the critical care transfer teams that have kind of evolved out of the COVID pandemic, so that they can instigate optimal, or what we would decide as optimal, management of cardiogenic shock when they reach the patient, including an in-transfer and then dropping them off to us. And then back to this point about leadership, I think that the network really needs to be supported by an education and training around the identification, the escalation in the referral centres and within shock centres, because one of the things that is clear, certainly in my experience, is that this is not a problem that is exclusive to district general hospitals. We see failure to rescue scenarios within our coronary care unit in our building, despite all my best efforts. So the education and training needs to be focused across the network. There needs to be the development of robust and kind of co-designed network protocols. We need to generate data to underpin quality improvement and audit activity. And in an ideal world, one of the other benefits of centralizing these patients is that we can enroll them in future clinical trials. Next slide, please. And as I say, one of the key kind of developments is embedding pathways of care and network protocols. So I think the biggest challenge, having gone round all the centres in my network and spoken to other referrers, is that, as I say, even when these patients are identified, the centres don't really know who to phone, when to phone, and what information that they need to make the referral. And so having those protocols, not just about identification and escalation, but also then what the onward referral pathway looks like, what the expectations of the referrers should be, is crucially important that we deliver this service robustly, resiliently, and with equity of access. Next slide, please. So how do we ensure kind of this equity of access? And again, this is underpinned by data from the US, which is demonstrated so that the concept of the heart team is very well established in elective cardiac care across structural intervention, EP, cardiothoracic surgery. But what has kind of evolved is this notion that we can provide a multi-professional shock team, which is a collection of specialists, shall we say, across cardiology, critical care, cardiothoracic surgery, anesthesia, and the cardiology subspecialties. And the benefit of providing that 24/7 is that even if the patient is remote from the cardiac centre, using IT platforms, we can bring that expertise to the patient's bedside, which hopefully overcomes some of the challenges of geography and equity of access to this expertise. And so what are the kind of upsides of that approach? Well, we can provide clinical support to referrers. We can support them in interpreting echo and the hemodynamic data that they may have available. We can push for the facilitation of interventions if not locally available. I mean, obviously we can't determine that, but what we can say, and one of the highest risk populations is the non-ST elevation myocardial infarction patients. We can really push for there to be a local intervention, and if that's not being supported, we can recommend them moving centrally. We can support the triage of patients to an appropriate care location, ideally within a cardiogenic shock centre. We may also be able to identify patients who are unlikely to benefit from advanced cardiac care. Using transfer protocols and networks, we can support the safe and timely transfer of select patients to the shock centre. And then, finally identify those patients who may benefit from mechanical circulatory support, be that when they arrive at the shock centre or by mobile MCS. Next slide, please. So how would that work in practice? Well, again, this is not kind of reinventing the wheel. And so what we propose is that we create a single point of contact. That single point of contact doesn't have to be a doctor. It can be a lead nurse or that is contacted, that the referral details are given. There is a minimum data set that is outlined across networked agreed protocols. It doesn't have to be a homogenous nationally at the shock centre, and that the duty shock clinician or coordinator would then manage that referral, establish the forum for an emergency meeting that would involve the referrer so that they could present the patient, and then an assembled shock team, ideally in real time, so within minutes, which recognises the acuity of these patients using well-established kind of IT platforms like Microsoft Teams. And then it doesn't, or it shouldn't stop there, that shock team then provides responsibility for the ongoing care of that patient, whether they are transferred or not. So there is a follow-up and there is a clear delineation of what the escalation plan is locally if that patient isn't to be transferred. And then if that patient is transferred, there is ongoing multi-professional input longitudinally over that patient's care, whether that be on the coronary care or whether that be the intensive care. And then subsequently, if that patient is repatriated to their referring hospital, there is a clear pathway of re-escalation and discharge advice, so that there is longitudinal care from multi-professionals across the patient pathway, which is what we're trying to implement. And I think one of the biggest changes that I've experienced in working together is that cardiologists and intensivists work much more collaboratively. The intensive care is now a kind of happy place for our cardiologists to pop into because they see familiar, friendly faces. There are shared goals. They understand cardiogenic shock. We understand their ways of working. And I think bringing people together, bringing specialties together is one of the real advantages of this type of kind of structured multi-professional approach. Next slide, please. So trying to kind of pull this all together, the kind of mantra of the document is about getting the right patient, so the patient who clearly has cardiogenic shock and not another etiology of shock, because, you know, whilst it has happened on occasion, what we don't want to be doing is moving hemorrhagic patients into shock centres where we may not have the 24/7 capability to manage them. Recognising that mixed shock, so those patients with combined septic and cardiogenic shock who are at the highest risk need to be triaged perhaps more aggressively, that we're not getting in the way of other pathways. So if this is a clear STEMI, that patient goes down the heart attack centre route and they can be supported in their local heart attack centre, and that if there are other etiologies that need specific intervention, be that pulmonary embolism, structural heart, tamponade, that patients go down that pathway, but the cardiogenic shock team is there to support them in their disease-specific intervention. Clearly, we need to get the patients at the right time, so early in the course of their syndrome, before the onset of multi-organ failure, because if they develop multi-organ failure, often that is the kind of the precursor to death. Having the right data to make decisions, so creating a minimum data set that is defined and refined locally based on clinical, biochemical and imaging data, also incorporating data around out-of-hospital cardiac arrest because of its impact and prognosis. And then having the right specialists in real time to make the decisions and support the referring team. So creating a shock multidisciplinary team of whatever flavor you feel is deliverable locally, but normally being correlate with cardiology, intervention, heart failure, critical care and cardiothoracic surgery. And then the right intervention. So as I say, this document is not designed to increase use of mechanical support. And a lot of the centres that have set this up in England, at least, have found that whilst their patient numbers have gone up, the MCS use proportionally has gone down because they get the patients earlier in their course and they're not needing to use mechanical circulatory support. And it may be that there are a cadre of patients who, just by virtue of being put in a cardiac intensive care, having advanced imaging, having advanced hemodynamics, and having access to cardiology subspecialties as well as critical care, that may be the sole intervention, or it may be that they need advanced electrophysiology, coronary intervention, and also bearing in mind that palliative care is an option in these patients with a high mortality, and that should not be forgotten about, and that palliative care needs to be embedded into all aspects of the pathway. Next slide, please. I'm going to put one slide up about mechanical circulatory support. I don't think it is the elephant in the room, and the way that we frame it is to say that it's an essential support modality in cardiogenic shock. I think for those of us that look after those patients, I think that's probably an immovable statement. So it needs to continue to be used nationally. I think the biggest challenge of it is that it is costly. And currently, at least in England and Wales, there is no governance over how it is used, who it's used in. And what we recommend in the document is that commissioning groups get a handle on that, not because we need reimbursement for the activity that we're providing, but what commissioning does is it provides a more robust audit and oversight of the use, which we currently don't have. And I think that needs to be developed. And I think, at least in NHS England, it is being explored. Next slide, please. And then finally, coming back to the first slide, we really need data to drive change. And again, I don't think this needs to be the development of new registries or data sets. I think what we need to do is to modify existing high quality national audits and data sets. We need to lever data linkage to ensure that we can look at patients across the pathway. And I think the other thing that I haven't spoken about is survivorship, and not just getting these patients kind of alive to discharge, but making sure that we understand what happens at the back end, what their heart failure burden is, what their healthcare utilization is like, what their quality of life is like. I think any data set should immediately be parsimonious. We don't need complex data. We just need to start with something. In an ideal world, because there is additional cost associated with this, particularly at the extreme end of these patients, some understanding of the health economics would be beneficial. And again, the other reason for this activity, and others are doing this in Scotland, is to really try and elevate the agenda within research funding bodies. I mean, Scotland particularly has an internationally renowned kind of history in cardiovascular research, but cardiogenic shock research, despite its mortality, is really not on the agenda of the main funding bodies, and we need to change that. And I think one of the vehicles to do that, aside from shock to survival and forums like this, is the engagement of patients. And I don't think, at least in my experience, we've done that well in cardiogenic shock, and kind of understanding from survivors what their care is like, what it is like to have cardiogenic shock, be supported by mechanical support, and live with the kind of sequelae of survivorship to drive the kind of agenda for change. And I think that's a really important message. Next slide, please. So just briefly, this is what we have developed locally in my sector. So it hopefully incorporates most, if not all, of what we've said. So we have these kind of posters, PDFs. There's an associated website if you want to go to it within the Barts Health domain. And all that we've done is ostensibly use the SCAI classification and the early recognition and urgent investigations within shock survival, and then added into that what we would recommend follows in terms of critical care and cardiology input, central and arterial access, starting inopressors. And then the biggest change is to access our shock call. How we run that within my hospital is that we have a third-party provider. We have an application-based system whereby the referrer goes onto a website, puts in clinical data, and then that sends out a real-time and resilient text message to the shock team. We get a text message on our phone within minutes, and then we press on the text message a phone number to dial into a real-time conference call. So, for example, without exaggerating, we have had a patient on the cath lab table. The interventional cardiologist has called us, and within 5 minutes, we've had 7 multi-professionals on the call to make a decision about escalation of that patient, and that patient was subsequently on mechanical support within 20 minutes of their index presentation. So it can work in practice. It doesn't always work like that, but that is the main change, is the referral to the shock team aside from local escalation. Next slide, please. So I will stop there. Hopefully that's given you some food for thought. I'd be really interested to hear from the kind of panel discussions about what their take-homes reflections are on that with reference to Scotland, and I'd be happy to field any questions in the discussion. But thanks again.
Thank you very much, Alistair, and thanks for going through and summarising so much that is in that report. I actually particularly like that graphic from Barts Health in terms of recognition. I can imagine that posting something similar up in our institution would be useful. So I think what we'll do now is, as you said, try and think about what this means for Scotland. So we'll move to the panel discussion phase. And now I'm really glad that we've been joined by a number of colleagues across Scotland who hopefully will give us a slightly different perspective on what this issue means to them. So first off, I'd like to go to Alex Warren. So Alex is a CT2 in ACCS in NHS Lothian, but he's also a visiting researcher in the University of Edinburgh. Alex, you've been involved in a study called the EPOCS study, and I know you presented it recently at the Scottish Intensive Care Society. One of the major issues identified by Alistair was the need for data. Tell us a bit about what EPOCS tells us about that data, and can you give us a sense of how big a problem cardiogenic shock may be in Scotland?
Yeah, thanks very much for offering me the opportunity to chat about EPOCS a bit. So this has really come about from lots of people who feel that we need to collect data on these patients in Scotland and have an idea about what happens to them. And since November, we've been collecting data at 13 different hospitals in Scotland. So from small rural district general hospitals all the way through to some of the larger tertiary and quaternary centres. And it's been going very well. So far, we've collected data on about 120 patients. And we think that in terms of the numbers, we're looking at somewhere between 35 to 40 patients in cardiogenic shock in Scotland each month. We haven't yet been able to sort of crunch the numbers on what percentages that means for sort of intensive care units, but we think for most general intensive care units, that represents probably somewhere between 2 and 5% of all their intensive care admissions. And obviously that's going to be higher at units with primary PCI services to admit larger proportions of those patients. But what we can see is that these patients don't only present to those hospitals with primary PCI capabilities, and that they frequently present to hospitals which aren't necessarily hospitals which have, for example, 24/7 cardiology specialty coverage. In terms of what happens to these patients, we know that there's significant variation in their management, and that includes things like, the use of invasive monitoring and pulmonary artery catheters, and even fairly straightforward things such as the initial vasopressor used to manage patients with hypotension, and that seems to vary both between different units and also within units as well. Now, that doesn't necessarily mean that there's not a massive evidence base in terms of that, in terms of cardiogenic shock, and others on this call are more qualified than me to talk about that, but it does suggest that there's different things happening in different places. In terms of their outcomes, for the data we have at the moment, the mortality at hospital discharge is about 49%. So, and as Dr. Proudfoot spoke to, within the half of patients who survive, our study doesn't have the resources to look at sort of survivorship and healthcare utilization, but we know from other studies in Europe and in the States that is significant, and that readmissions are significant as well. And the final point I would make is again, things that Alistair was talking about in terms of mechanical circulatory support. Our data showed that was actually used in 1 in 3 patients with cardiogenic shock. Now, I think that might be a slight overestimate, because we have probably preferential recruitment or better recruitment at the moment from the centres which are able to offer that. What we can probably say, and what some of this data will help us say once we have the full analysis complete, is that there may be patients who might benefit from that, who don't currently have access to it, and whether that's because of challenges in recognition or challenges in streamlining in pathways. I don't think is clear, but I think that is likely to represent a small amount of patients who may have, who may be able to have different outcomes in a system which is geared up towards that.
Thanks very much, Alex, and certainly that mortality figure is quite striking. I'll move on now to Claire Gordon. So Claire, you work as an acute medicine physician in the Western General in Edinburgh, in a hospital that has cardiology service, but not a 24/7 cardiology coverage. We've heard the data from Alex. In terms of your clinical experience, particularly in the post-pandemic period where you've been assessing patients in a busy acute hospital, is this condition a condition we always spot, or is it challenging? Is it easily missed in your experience?
So I do think it's a very difficult condition to diagnose, particularly at the start. It's usually one of these things that gradually bits of evidence creep towards, and you exclude other things. So when you get more information, you're like, well, actually, this isn't sepsis, or like Alistair said, they're not really responding to fluids, or they're responding in a way that I did not want them to respond to fluids. And you've gone down the, is this a massive PE route? So it's usually more, unless someone's come in, like Alistair said again, with a stonking MI, or they've got a very bad ventricle anyway, or they're behaving in a very old cardiac way, attacking dysrhythmia, then usually it's a diagnosis that more sort of creeps up on you because other things are excluded, or you're still trying to get to the bottom of why they've got a shock liver and they're in acute kidney injury and their lactate's high and they look so rubbish, and you can't really find a cause, because usually at that stage you don't have access to an echo. And yeah, so I think it is actually quite a difficult diagnosis to make unless it's a barn door, MI type situation, or someone who's known to have a pretty bad ventricle anyway and something's just tipped them over.
Thanks, Claire. And I suppose feeding on from that, one of the major things that kind of in terms of that initial assessment and pickup that Alistair mentioned is the easy access to particularly out of hours echo. Is that something you have a challenge with in your own hospital? And do you think the increased uptake of acute physicians using point of care echo is a way to kind of improve that access?
Yeah, so I think we do struggle for echo out of hours. And at weekends, a weekend is a long time. You will get a cardiology registrar visiting, but they're not always, like, I had to force the last weekend I was on call, I had to pretty much force them to do an echo. I've done a bit of bedside echo. I was on with an intensivist who could do echo. So, you may be lucky and have some skills in the department that allow you to do some rudimentary echo. Like you say, more intensivists are able to do it. More acute medicine is going to be, we're all going to be able to do bedside ultrasound, and that can help in terms of at least looking at the lungs. But we're not trained in bedside echo unless you do it specifically. But absolutely, I think it's something that would benefit, being able to make the diagnosis more at the front door, and not have to wait for someone who's gone through lots and lots of training, or a specific cardiologist to come and make the diagnosis. And I do think it is becoming more of a skill within acute medicine and emergency medicine and intensive care. And also, there's quite a lot of transferable skills in terms of ultrasound and echo. Yes, they're not the same, but for example, for me, a lot of it's just getting my head around which direction I'm wanting to point the probe in and twist the probe, and that's something that makes a bit of sense once you've done one.
Thanks very much, Claire. I'd like to bring in Stephen Freer from NHS Grampian now, if that's okay. So Stephen is a consultant intensivist up in ARI, and has also been the local lead within NHS Grampian for the deteriorating patient programme. Stephen, this is obviously a complex problem. There are complex systems involved. There may be complex solutions, and there's lots that we could focus in NHS Scotland in terms of trying to improve things. What do you think that are the major kind of next steps you should be focusing on from a quality improvement point of view? What's the low-hanging fruit in this area, do you think?
Yeah, I think it kind of goes back to that. I know that, Alistair was saying about mechanical support is always the elephant in the room, or whatever. But it goes back to quality improvement. I think doing the simple things really, really well is always the crux of quality improvement. It's identifying those patients, and even in sepsis, we're not great at that. Whenever we look at news scores, we're not actually even really good at adding those up. And so, electronic OBS and stuff like that would be really helpful, but actually just focusing on that. I was chatting to a group of nurses about quality improvement. I said it's a bit like Where's Wally. Whenever we see the Where's Wally, it's trying to identify that one patient in there, and like some of us are good at just pointing straight at Wally, but some of us aren't. So it's what Osler said, expertise is about seeing it well. It's not about seeing lots of things, it's about seeing it well. And it's how we take that small group knowledge. So it's how we take maybe my ability, I would say I'm an expert at this, but my enhanced ability and putting that out to everybody so everybody knows that. So, does news work for this? I think that was, discussed in the report. in working on the indicators we can see, mottling, pulse pressures and so on. And then, some of the stuff already in place, so then driving that up, so standardized escalation processes. And then I think what Claire was chatting about, that echo, because it's very true, anybody can order a CT, but getting an echo is never as easy. So, with a different hat on, with a TPD hat on, that FICE training, that focus training is coming through in critical care, for example, all our trainees getting skilled up in that, I think is really important. So we take it from recognizing it to actually escalating it to actually identifying it. And if we can get that far, that's the low-hanging fruit. Then we can actually start to work out the systems we put in place to actually do something about it.
Thanks, Stephen. I suppose it's pulling on us who are kind of directly involved with the SPSP program when we're developing the tools such as the structured response to make sure there's a natural bit where people are going to think, hang on, this patient is hypoperfused. I need to get some out of hours imaging here in case there's something else going on. This may not be sepsis. Thanks very much. I'd like to turn to colleagues at the Golden Jubilee now, if that's okay. So I'd like to bring in consultant cardiologist Paul Riccocilli. Paul, you work in a quaternary cardiac centre, Scotland's quaternary cardiac centre, and quite rightly so. A lot of the Golden Jubilee's focus in terms of the advanced heart failure service is heart transplantation programme. You'll get calls from all of us. Sometimes it's me on the end of the phone with a patient who's possibly in quite advanced cardiogenic shock. From those referrals and those contacts with the other boards that are referring in, what's your major message in all of this work? What's your major ask of all of us who are kind of often trying to get advice from yourselves, kind of with a patient who is very unwell?
Thanks, Gregor. I mean, I guess, well, the first kind of point about me is I'm an interventionalist, but I work very closely with the kind of shock team within our organization, which is fairly nascent. And I think it's probably the same for me as it is for you, in that it's just knowing who to contact and, having the pathways clearly available, understanding when to call for help, whether it's me calling for help from the cath lab and someone who's sliding from stage C to D shock, or it's someone calling from a AAU in a peripheral hospital, someone who they think is in developing shock. Having that clarity is important. My colleagues within the advanced heart failure service and the transplant service specifically, over time, have developed standardized processes for referral. Caroline, who's on the call, I think will remember, the creation of the web referral system. There's, a page holder. These things are fairly simple, but having someone 24/7 carrying a page to take calls for query advanced heart failure referrals into our centre, or mechanical circulatory support calls into our centre, is transformative. Because prior to that, it was, well, do you call ICU? Do you call cardiology? Do you call the transplant cardiologist? So standardising things as much as possible so that it's easy to find Wally, whether he is right beside you or, in another building or at home.
Thanks very much, Paul. And do you think one of the ways I suppose we can standardise is kind of talking to each other? I mean, we've heard about the challenges in a very complex landscape in NHS in England from Alistair. Do you think are there potentially more opportunities? We are a small country of 5 million. We have 3 cardiac centres. Is there opportunity potentially for us to discuss more amongst the boards about these processes and potentially standardise them further?
I would hope so, and I think with IT systems and the ability to set up an MDT call at whatever time of day, even if you're at home, allows us to be much more reactive and dynamic in how we respond to cases. I think we need to build on the my thought would be that we need to build on the established networks that we have. We probably do need to disrupt that a little bit, considering the challenges of, delivering the kind of service that's or services that are described in the document. I reflect back when I was very much involved in both NHS England and NHS Scotland cardiac arrest strategy work. And, we still don't have recognised cardiac arrest centres either in Scotland or in England. They're essentially just heart attack centres. And it's accepted that even, the recent BISUS consensus document, it's accepted that there is no such thing yet in the UK as a cardiac arrest centre, but it's about having the right people who understand patient selection, who've got the expertise to make some decisions, to guide local clinicians. And as Alistair said in his presentation, a bit of a gatekeeper in and out of the centre in determining who needs to come and what interventions might be useful to avoid someone coming. I think we can build on the pathways that we have already. And again, I think we need to be a bit disruptive, and that will mean money. It's going to mean more beds, more skills, and sharing that skill across the country.
Thanks very much, Paul. I'd like to bring in your colleague Neil Brain. So Neil is an intensivist at Golden Jubilee. Neil, you probably see the absolute pinnacle of these patients in Scotland, a very select group. From those patients are coming into your service. What learning do you have in terms of what we should be focusing on going forward?
So I guess going back to what we described as the low-hanging fruit, the kind of early recognition is a massive part of it, isn't it? Getting access to echo for these patients that we've screened out using the kind of early warning scores as being at risk of having cardiogenic shock, and trying to identify them at that stage. And I guess the next level of screening beyond that I think is likely to help when referring into our centre is making some attempts at measuring cardiac output, be that with a pulmonary artery catheter or image, with echo, trying to estimate cardiac output. And then I think it's about speaking the same language, isn't it, between the referring centre and the receiving centre, and using things like the SKY criteria to describe where you think the patient is at that point in time and the direction of travel.
Thanks very much. I mean, I suppose, as Paul's already alluded to, that, some of this may take money, as was that is out with the realm of our kind of SPSP program, where we're really trying to focus on quality improvement. But do you think are many of these resources within our current systems in Scotland? Is it more about just reorganising care and communicating between our teams?
I guess we've got the ability to provide a lot of it, don't we, already? And we don't know how big the problem is completely. We're working on that at the moment with things like Alex's EPOC study. It'll help us identify the denominator. I guess I've heard Alistair speak before, and he said that whenever you talk about this sort of thing, there's a lot of concern around how expensive it is going to be to deliver, because there's a focus is on that very top kind of highly invasive, highly expensive bracket. But actually that's probably a really small number of patients that are going to need that, and it's probably not going to be a magnitude different to the number of patients we provide that sort of care for at the moment. We do a lot of this already. It's not like there's no patients in Scotland that have cardiogenic shock that get advanced heart failure treatment. So there's a lot that exists already, and there's lots of investment in that already. And I think we provide quite a good service for those patients. I think there's probably more of the focus will be further down that pyramid, won't it? Of maybe there probably will be a bit of preventing people getting to those advanced stages, and the earlier you recognise them, the earlier you can intervene. Presumably, less patients will go on to more advanced stages of illness, and hopefully less of them will need kind of more advanced therapies.
Thanks very much, Neil. I'm conscious that we bring in comments and questions from the wider group on the call, but I'll go back to Paul. Paul, please.
Yeah, I just wanted to re-emphasize the point Neil made there around speaking the same language. I think that's absolutely critical, and it's probably the most disruptive thing we could do, or could be transformative, if we all spoke the same language. We had the same infographics in every centre, every ED, AAU, every cath lab, and even within our centre, there's variation in practice, and it's going back again to Alistair's presentation and the discussions there. It's about trying to kind of homogenize this as much as possible, to learn from what's been done in sepsis 6, to to shift away from the old models of how you should monitor patients in coronary cares. We're just in this unit about to move to News 2 in our coronary care unit, and that seems like a huge change for us, but actually it just takes a bit of persuasion, some work, some education, and I think you've got the key people on this call who are keen to be involved in affecting that change. It's just about moving it forward.
Gregor, I think you spoke when you were on mute.
Oh, thank you. Sorry, Alex, please.
Hi, just to say about the health economic side of things, I think that's something that we could really do with some data on. And all we can say from what we've looked at our data is these patients prior to their admission, the vast majority of them, well over 3/4, have a very low frailty score, so 3 or less. So this is a group of patients who, whilst they're a similar age to critical care patients in general, so the median age about 60, the vast majority of them are fit or very fit, many of them economically active, and many of them with the presence to potentially return to economic activity. And I'm sure that those of us who've worked with these patients clinically will know those stories of the people who are referred to as good saves or whatever, who get significantly good both personal and economic outcomes. I think that's something that we can't underestimate when we try and develop services and pathways for them.
Thanks very much, Alex. And yeah, I think it's very interesting, isn't it? If you tie that in and you add that to the mortality you described in this group, and many of us feel this, I think, as Claire said, working in clinical practice right now, patients are finding it difficult to access their GP. They are presenting late with their MI. It feels to me anyway like we're seeing more of this. Thank you all for those discussion points. I thought that was really useful. I'd like to widen it out to the other attendees on the call. Does anyone have any comments on what they heard so far? Any questions for the panel from Scotland, but also from Alistair? If you do, please raise your hand or put something in the chat. If you can, I'm hoping you can. While we're waiting for people to comment or raise their hand, if I could go back to Alistair. Alistair, we've heard a lot about thoughts from various people across Scotland. And again, I think you've already alluded to this, but as an outsider looking in, compared to kind of health systems in NHS England, what would your comment be about how fit we are in Scotland to kind of take this issue forward?
I think you're on mute, Alistair. Alistair, I think you're on mute there.
Yeah, sorry. Sorry. So there's no doubt to my mind that you're already offering, as Neil says, a high quality service. And I think what that lends itself to, so whether it be the geography, I think is a problem, and that's one of the, that not to say that doesn't exist in the Southwest Peninsula and Wales and across areas of England, but I think the geography to my mind, is one of the potential barriers. But with this type of activity, with the way that Golden Jubilee seems to already be working, at a national or international class level for advanced heart failure referrals, I think all the substrate is there. And I keep on saying it, and others have said it, but I think because your foundation is strong, the actual change that will be required, the echo piece aside, is probably pretty marginal, and it's more about just embedding the structures, as Paul said, creating a standardized pathway, creating standardized infographics, and most of that can be delivered fairly efficiently in a and I think all those low-hanging fruit that people have spoken to is imminently deliverable. And in many ways, I'm listening to it feeling somewhat jealous because, yes, I can do it at a regional level, but having any, quality assurance that we can do it at a national level in England is pretty small. But I really get the sense from what's been said here that there is an opportunity with, with pretty, low-cost measures to make a massive change, as I say, because you've got the foundations there. So I'm going to leave this with jealousy, unfortunately.
Thanks very much, Alistair. You can come back in 5 years' time. Hopefully, we're not still having the exact same conversation. For those on the call, I mean, we're very lucky today. We've got people joining us from a variety of boards across Scotland. I suppose it's very easy with all of this for us to get into our centric bubbles, whether we're speaking from NHS Grampian, NHS Lothian, or the Golden Jubilee. We all have kind of cardiac surgical centres embedded. That may bias us. Is anyone who has joined us from kind of any of the other boards, is this an issue you're seeing as well? I'm just reading a comment from Ashley, who's joining us from GGC. So I was wondering if there's any thoughts to move to an outreach service in Scotland to assess these patients, potentially with cardiac output equipment. I mean, I think that is a really interesting point. We are looking at outreach as part of the update to the SIGN guidelines in Scotland. We don't currently, apart from in a couple of boards, have an outreach system in NHS Scotland. Alistair, how you will obviously have had a well-embedded critical care outreach service within your own hospital. How crucial is outreach in terms of identifying these patients for you?
I think it slightly speaks to Claire's point. So, I mean, I'm in a slightly odd position in the sense that, the 90% of the patients in my hospital, if you have shock, you've got cardiogenic shock, and I'm sure that's the same for Paul and Neil. And so your buzzers are going off if the patient is hypoperfused or hypotensive. So it's a bit easier. I think the big challenge, not just for critical care outreach, but for everyone, is what Claire was speaking to, is that often, unless it's the kind of fulminant myocarditis patient where you're throwing the book at them and everybody's kind of involved, it's the slow burns that often present the biggest risk. And I think that's a challenge to not just critical care outreach, it's a challenge to senior doctors and all doctors kind of in between. And I think the thing about critical care outreach, and one of the things I always say in a kind of QI activity is that if you want something done well, don't ask medical staff. And what critical care outreach are very good at is following a protocolized escalation. And now, whether they will get the response from the senior doctors that protocolized escalation demands within the SOP is a separate issue. But what our outreach are very good at doing, both in terms of in Bart's Heart Centre and within our network, is flagging the patient who is sick and also flagging the patient who is not responding. And it's almost that second group that I think critical care outreach have a key role to play, because the diagnostics, because unless we develop, and it's not implausible, and I've been looking at AI technology for critical care outreach to do basic echo. But what critical care outreach are very good at saying, well, you've given fluids, you've given antibiotics, and the patient's still hypotensive, they're still oliguric, their lactate is going up. And I think it's using that mechanism for the red flag of the patient who's not responding, which is often the kind of slow burn patient that Claire speaks to. And I think that critical care outreach are much better at that, in my kind of anecdotal experience, which isn't a very high level of evidence, but at flagging those patients, whereas doctors, you know, are not so good. And there's a bit of, you know, kind of hubris about, well, you know, this is the diagnosis and I'm going to follow it through by giving more fluids. And I think that's where one of the real benefits of outreach, I think, have manifested in our network at least.
Thanks, Alistair. That is really interesting, and outreach may be something that we look again at in NHS Scotland going forward. I'm just looking at the comment from Robert Docking in GGC. If we follow this through, potentially there will be a push to move patients to either tertiary or quaternary cardiac centres. How are we set at the moment to deliver this in terms of volume, space, etc., and the impact it may have on current work streams such as transplant work or cardiothoracic elective flow? So I suppose, Neil, you may have thoughts on that. Stephen, with your experience of the kind of VV network across Scotland, you may have comments on that as well. Can I go to Neil first, please?
Yeah, thanks. I guess it's probably a similar point to Ash was making as well about, you know, there's a balance there, isn't there, between taking the treatment to the patient and bringing the patient to where the treatment is available. And I think in a fully formed network, you need to have the ability to do both of those things and have the technology to share information between the two sites. So being able to look at the echoes together, being able to look at the patient's imaging and blood results and all of those things. And we've got a lot of that infrastructure in place in Scotland already. I think to be able to deliver all the things in the document we've described, I guess certainly in our centre and probably in the other regional centres, there would need to be a bit of thought about how a sort of retrieval service would look and how that would be formulated and staffed and things. And I think that probably leads on to the same point that Bob has made. I think that the most limiting resource in the system is likely to be the people in it rather than anything else. Like, you know, I'm sure it's the same case in everyone else's intensive cares at the moment, but physical space isn't the most limiting factor for us. Certainly, it's the expertise and the knowledge of the staff that are in there to be able to care for the patients. And I think that is the biggest limit on our transplant and cardiothoracic surgical program at the moment, is having, you know, all of the staff in place from intensive care, ward, theatre, everything else to put care for these patients. And I guess that will continue to be the limiting step probably for any other broader group of patients. I think there's obviously, as we've already alluded to, there's that's certainly one of the risks, isn't it, of that people are worried about, is identifying lots of patients out there that potentially would need to be transferred to our site or the other regional cardiac intensive care sites for advanced therapies that might impact on services. And I think that, as with the other kind of regional network types of care across Scotland and the rest of the NHS, part of that ability to deliver that is going to be made possible by moving patients back in the other direction, albeit at the other end of their care. So, you know, your post-PCI patients going back to CCUs and other health boards, your post-cardiac surgery patients maybe needing to move back to their local health boards, that kind of idea. And further downstream at HDU and ward level, that there's going to have, you know, if you want to deliver one thing, you're going to have to compromise at some stage unless you have an infinite amount of resource to throw at the problem. I think that that's likely to be how you kind of juggle those two things.
Thanks, Neil. Alistair, please.
Yeah, I think Neil just is absolutely right. So what I didn't speak to, which I probably should have done, was that notion that I mean, my managers say this, you know, where you're going to take up elective cardiothoracic surgical capacity and that's commissioned work. I think my retort to that is that this is not, you're not manufacturing a new group of patients. These patients exist already. All you're doing is providing care for them and what the team, the shock team and the referrer believes to be the most appropriate location of care. And what's incumbent on me and my colleagues is, as Neil eloquently highlights, is to move the patients that are at the back end of their trajectory out the other end. Now, yes, you may end up with a degree of net positivity, but I don't think the impact, and certainly having set it up at bars, we are not overwhelmed by these populations. And what it means is you just have to use your network more efficiently. And actually, you know, in theory, the having a cardiogenic shock patient languishing in a district general for 20 days is much less efficient than turning them around in a cardiothoracic centre in 5 or 6 days, particularly if you move your back end patients at the cardiothoracic centres out the other way. And I think we just need to be mindful of that, as we already are. Again, this is not reinventing the wheel. It's just being a bit more meticulous about how we manage our resource.
Thanks very much, Alistair. I'm conscious of time. I think I'm going to bring that Q&A to a close. Thank you again for all the speakers from the panel, and thank you for those who posted questions or comments in the chat. We'll bring up the slide sets now again, and I'll just kind of talk to you about some next steps. So it's quite difficult for me to pull all that together from what's been a kind of a really rich session, but I think we have heard that, you know, cardiogenic shock is a live issue here in Scotland, but we maybe have many of the resources already to improve care. And certainly it's been really useful hearing from all the speakers on the call today, and I'm sure they can take this forward with further clinical meetings to drive those low-hanging fruit for early identification and to ensure that we're all in some ways speaking the same language, and certainly from there hopefully we can improve care and improve timely care. In terms of a few more dates for your diary, in terms of the overall SPSP programme for deteriorating patients, we have an acute adult learning event on the 20th of April. There are kind of specific invites to boards for that. So if you are joining us then, looking forward to that. We will be taking learning from across the UK in terms of deteriorating patients, and we're really excited to be joined by Chris Suby from NHS Wales, who's done a lot in terms of identifying metrics to use to identify deteriorating patients. So he'll be speaking, and hopefully that'll be a really good in-person event. Another point for you all is that we are moving forward with the publication of Sign 139 patient deterioration. And we're hoping that will be published towards the middle of the year. That may well be relevant to the topic we've discussed today, and we'll look at things such as observations, electronic observations, but also things like the use of outreach to identify deteriorating patients. It's going to hopefully move the conversation on quite a lot since the original guideline was published in 2014, and will be going out for consultation. So if this is an area of interest for you, please have a look at that when it is published in consultation phase. Beyond that, following the publication of the Sign 139 guideline, we are looking within SPSP to revise our sepsis driver diagram. We've talked today how we don't want sepsis to be the full and only focus of our quality improvement work in terms of the deteriorating patient. We don't want to miss those patients with cardiogenic shock. But certainly, following the publication of Sign 139 and recent other papers looking at sepsis, such as the AMROC paper, we felt it was right to revisit our own SPSP driver diagram and tweak things going forward to ensure we are still identifying patients early with sepsis, but maybe slightly being less trigger happy with our antibiotics. So thank you again for all to all our speakers today, and thank you for all for attending. There will be an opportunity for feedback, and thank you again for taking the time to join us today. If you look in the chat now, you'll see the feedback forms. Please fill those in, and we can use the feedback to improve the way we run these webinars, and hopefully give you kind of further information about the deteriorating patient going forward in the coming webinars later in the year. So thank you again. Goodbye.